Welcome to today's webinar on the ProAct solution for employee prescription benefits. My name is Mark Levine, and I'm the Deputy Director of your New York State Association of Counties. Thank you for taking the time out of your day today to participate in this timely webinar discussing opportunities for employee prescription benefits. For the past decade, NYSAC has been working with ProAct to deliver lower cost prescription drugs to residents through a prescription drug benefit card and to employees of counties and New York companies with self-insured health insurance benefits. ProAct is a New York-based company that is also the nation's only 100% employee-owned pharmacy benefit manager. Since 1999, they've been invested in helping their clients, including dozens of counties and local governments throughout the state, deliver better prescription coverage at a more competitive price. This webinar will focus on opportunities counties have to save money on their overall health insurance coverage with solutions that tackle the increasing costs of prescription drugs and ways to contain specialty drug costs. Jeanette, I would like to turn it over to you now for any housekeeping announcements.
Thank you, Mark. Just a couple of pointers before we begin. We will be recording this webinar and we will post it on our NYSAC website at nysac.org under webinars. Just look under archive webinars directly under today's date and you will find the recording as well as a PDF of the slide deck. We also encourage you to feel free to submit questions throughout the presentation. We ask you to do so by clicking on your dashboard's questions tab, typing in your question, and then pressing submit. We will get to all questions during the Q&A portion directly following the presentation. Back to you, Mark.
Thank you. That's Jeanette Stanziano. She's the NYSAC Director of Education and Training. Thank you, Jeanette. Our speaker today is a good friend of mine and ours, Erison Rodriguez. He's the Chief Growth Officer for ProAct. Erison has been with the company for nearly 14 years, having started with his career with ProAct as an intern while finishing his MBA. He has been lucky enough to have a front row seat to the significant growth that ProAct has seen over the years. And today he serves clients and members in virtually every state across the country. Thank you for joining us. We appreciate your time and your expertise. Erison, I now turn the slides over to you.
Excellent. Thank you so much, Mark. Appreciate the introduction, and obviously we're huge fans and partners of NYSAC over the past over 10 years at this point. So the intent of the discussion today is certainly not to come across as an opportunistic discussion to purely highlight ProAct's value as a PBM, but more so, honestly, to leave everyone with a little bit of additional information or context relative to the PBM industry that might generate downstream value to their overall pharmacy spend as it relates to their employees. And if there's a place or a time for discussion relative to how ProAct specifically could help those municipalities, we're happy to have those discussions. But what I find that is most effective is when these discussions happen or come from the standpoint of educating the audience. So with that being said, I've got some slides here, but it's definitely not intended to be death by PowerPoint. I'm hopeful that there's some value in some of the content that's in the slides. So with that being said, we'll go ahead and get started. So this slide, just kind of giving a recap of the market as it exists today. So starting on the left-hand side, the projected prescription drug cost trends are slated to be roughly 5% for 2022. So that in an industry that is significantly plaguing municipalities, school districts, even private employer groups, as if the issue wasn't large enough to begin with. We're not necessarily seeing some relief in sight. So as you can see, the projected cost trend sits at about 5% for this year. Hyper specifically on the specialty drug side, that's where most of the time, attention, and pain is honestly being driven from within the PBM space. So for context, I'm sure everyone listening again has some perspective on what a specialty drug is. For those that don't, specialty drugs are classified as usually have a few set of characteristics, right? They're high cost, require special handlings, require special handling in terms of shipping and temperature controlled containers. And they're often used to treat very acute conditions or life-altering conditions, including oncology, multiple sclerosis, HIV, things of that nature. So these are conditions that are life-altering for the patients being plagued by these conditions, but that are not necessarily being used throughout a wide span of the population. And as you can see in the second bullet, across our entire book of business, roughly 0.8%, so less than 1% of our total claims volume or total fills account for about 41.5% of total drug spend. So if you think about that, at a high level, roughly 1 in every 100 prescriptions dispensed on behalf of a municipality's pharmacy benefit plan is driving 41.5% of the spend. So obviously a lot of time and a lot of attention and significance relative to the specialty drug space. So that's where a lot of our focus is as PBMs, is how do we curb and mitigate some of the cost trends that we're seeing on the specialty drug side. And a couple slides down during the presentation, we'll highlight some of those strategies that have proven very effective. So the average cost of a specialty drug sits at about $5,200. So relative to what might be a maintenance medication used to treat diabetes, high blood pressure, or cholesterol, that might be $30 to $50 in cost to the plan. These specialty drugs are driving thousands of dollars in terms of cost. Specific to municipalities, that's significant, right? Because when there's cost share measures in place, we often see that on the private employer group side, the copay on a $5,000 specialty drug to the member might be $500 or $1,000. So there's some cost share where the employee or dependent has some skin in the game. We know that by nature, municipal plans are very robust and generous in terms of benefits, right? These are oftentimes union negotiated benefits. So the employee's cost share on a $5,200 drug might be a mere $5 or $10, right? So there's not a lot of skin in the game as far as the members concerned, but we'll talk about that a bit further as we proceed in the discussion. And then on the third bullet on the challenges side, continued PBM consolidation. One of the beauties of our industry is that we continuously see new market entrants, and by nature, competition tends to drive down costs. Unfortunately, on the PBM side, we've actually seen the inverse happen. So what happens is roughly I would estimate 10 to 15 new PBMs enter the market every year. They gain some momentum with a unique value proposition, and like clockwork, what happens is they gain up some traction, they build up their membership base, their client base, and 2 to 3 years later, when they reach maybe a couple 100,000 in covered member lives, they're acquired or merged with another PBM. And what you typically don't see downstream after a transaction like that is the hardship and disruption that happens to, in this case, a municipality and or their member base. So we continue to see that. Probably the most recent acquisition or merger activity that occurred was actually Magellan, that was actually divested over the past couple months. In terms of value, this is probably the most opportunistic part of the presentation. what the value that we feel we bring relative to some of the challenges that exists in the industry, I could probably wholeheartedly focus on 2 or 3 of these. The first one being our ownership structure. So we are 100% employee owned. In fact, we're the only employee owned PBM in the country. That means that rather than answering to Wall Street, mainstream, or venture capitalist board down in New York City or San Francisco, we ultimately answer to each other as employee owners. And we feel that that puts us in a very unique position within the PBM industry. In terms of value proposition, the fact is what the landscape looks like today is on the market today, there's probably about 95 PBMs on the market within the US serving US employers and their dependents. Of those 95 PBMs on the market today, the top 5 control about 90 to 95% of the market. So quick math, that leaves us, and us included, in a pool of about 90 other PBMs fighting for 5% market share. So the days in which you can enter these types of discussions and drive a webinar such as this one and purely focus on pricing discount, rebates, and clinical programs are long behind us, because the truth is the next 20 PBMs that were to present to one of the municipalities listening in today would have the same talking points. We've got the best pricing, best clinical, less rebates. Well, that's not unique. So for us, our ownership structure truly is what drives our value proposition. And we feel that it matters for 2 key reasons. The first one being addresses that challenges bullet point, the third one on the left-hand side. Because of our ownership structure being 100% employee owned, we cannot be bought or sold. So we are afforded the ability to prevent our clients and members from having to go through the hardships associated with a merger or an acquisition. And the second one is ultimately any PBM that is publicly traded, or any organization to that point that is publicly traded or has an infusion of venture capitalist funding, their sole purpose for existence is to increase shareholder value. So every decision that's made within those types of organizations centers around what is going to increase shareholder value and appease Wall Street and analysts down in New York City. And because we're 100% employee owned, we have the ability to make decisions that are not wholeheartedly focused on what's going to increase shareholder value. So while we're not bringing on new clients at the rate at which the big 3 PBMs do, we also don't aspire to. We understand that there's value in the long-term retention of clients. So the ones that we are fortunate enough to call partners someday do tend to stay with us for a very long time. So, and it's indicative by our 95.3% client retention rate. We're pleased to say that we have grown our business 100% organically since 1999. So we introduced our PBM division in 1999 in what we classify as Kinney Country, which is Central New York, Northern New York, and Vermont. And we just took a grassroots approach to growing this division, building relationships in the communities in which Kinney drugs dating back to 1903 had set their roots. So you think of the St. Lawrence counties of the world, in those really historic communities where Kinney's dates back to 1903. We went door to door knocking on building relationships with municipalities in hopes that if and when it was time to discuss their employee prescription plans, that we would have a relationship to leverage in that point. Next slide, please. Company overview specific to ProAct. We are part of a $2 billion organization, provider of pharmacy healthcare services with over 4,000 employee owners nationwide. The lion's share of which are actually domiciled right here in New York State. So paying New York State taxes, sending their children to New York State school districts up and down the thruway corridor, and we're proud to continue to support the communities in which we have brick and mortar locations. We also do own and operate our own mail order and specialty pharmacies that are domiciled right here in East Syracuse. And as Mark mentioned, to open up the discussion, we do serve a client base that's nationwide with regional offices across the country. And we are headquartered in New York. Next slide. So in terms of differentiators, this kind of pokes back a little bit at the statement I made a couple minutes ago, in the sense that, you know, there are many out there that would say that, you know, the PBMs on the market today have become commoditized, right? We all look, sound, and feel the same, which forces our hand to focus on elements that stand beyond the most basic of necessities or expectations by clients from a PBM. That's why we're highlighting that, you know, a vendor does all the basic functionalities of adjudicating claims, invoicing the client, managing a network, formulary, and clinical programs. But it's really, you know, the ancillary efforts and strategies that really sets the tempo for a successful plan for both municipalities, school districts, and private employer groups, and focused on listening to the client's needs, setting up on-site client reviews, regardless of the size of the client. We're fortunate enough to be headquartered right here in East Syracuse, which means that we can get to virtually any corner of the state within a couple hours. And believe me, now that, you know, the world has opened back up, we are in the car pretty regularly, traveling and meeting on site with clients, supporting open enrollment meetings, health fairs, benefit fairs, you name it, we're there to support those clients. So, and as I stated, again, we are 100% employee owned, and our growth has been 100% organic thus far. Next slide. So when we typically host webinars, we do focus on the 3 pillars that tend to drive any PBM's operational performances. So focused on client services, so at the client level, so at the municipal level itself, we focus on cost containment solutions. How do we mitigate rising costs? How do we deploy solutions that actually have the ability to drive that lowest net cost for our partners? And then member services, so at the actual employee or dependent level. For the purposes of this discussion, obviously the intent is to highlight strategies that have the ability to really mitigate some of the cost trends that we're seeing. So we're going to focus on the center element that we have on the screen today, which is cost containment. So we're going to walk through probably another handful of slides that's hyper specifically focus on cost containment solutions, and then we'll have some Q&A at the end. So next slide, please. So home delivery, in terms of path of least resistance, this is probably the lowest hanging fruit that we find tends not to be leveraged very effectively. Home delivery, so it's mail order, getting your maintenance medications, so therapies that are being taken month to month to treat ongoing conditions, high blood pressure, cholesterol, diabetes, asthma, things like that, that you're getting on a regular basis. You get refills from your provider. Again, going back to the very generous benefits that municipalities tend to have in place, they also extend for members to have the ability to get 90-day supplies at retail, which is obviously significantly convenient to the members. But there also is some significant value to having maintenance medications filled through a mail order facility. So conversely, looking at a brick and mortar location, they have lots of overhead with employees, maintaining a building, pharmacists, lack of automation. Those are all factors that actually add to the overall cost of fulfillment for that particular medication, that maintenance medication. What mail order allows PBMs to do is to really leverage automation. So our central fill location in Governor, New York, actually has robotics in place that actually picks prescriptions, fills them 24/7 up north, and then sends those prescriptions to our mail order facility that then actually puts them in the U.S. Post Office mail service and gets them delivered to the members within 2 to 3 business days typically. So we're obviously always encouraging our municipal partners to consider introducing a mail order program incentive where perhaps there's a reduced copay on mail order. You might be paying 3 times the 30-day copay at retail, but we've had municipalities and partners that introduce a 1 copay override or the waiving of 1 copay for any members that utilize mail order for their maintenance medications. It allows us to constantly monitor the utilization to more effectively deploy generic availability notices. So if there's any members that happen to be taking a brand name maintenance medication that has a generic alternative, we would be reaching out, engaging those members on an ongoing basis, hopefully with the intent of influencing that behavior to switch to a generic alternative that not only saves them as a member dollars on their copay, but obviously significantly to the municipality reduces their costs as well. Compliance campaigns, we can't say it enough how many lapses in therapies we see naturally occurring in the retail setting. The mail order setting does afford us the ability to send push notifications via our app, actual mailing campaigns to ensure that members are getting healthy and remaining healthy and compliant on their therapies. Rapid drug recall notification, because we're owning the dispensing process of any of these therapies. Should there be, in the event of a recall, we have the ability to engage those members much more effectively versus relying on the retail setting to engage with members on that level. And then voucher incentives, that's again an incentive to transfer maintenance medications from the retail setting to mail order, and we find those to be pretty effective. We also have the automatic refill programs in place where the members receive a 90-day supply, and roughly at about the 65-day mark, a new prescription is pushed into queue and ultimately mailed to ensure that there's no lapses in the supply for that member. Next slide. So on the specialty pharmacy side, I did mention we own and operate our own mail order pharmacy, our own specialty pharmacy that is domiciled in East Syracuse, strategically located to be able to serve the needs of any specialty patients via overnight mail. And if you're within a 60-mile radius of our specialty pharmacy here in Syracuse, in East Syracuse, we also have the potential for same-day delivery. Or if you happen to be in Onondaga County or Oswego County, you can take the short drive over to our specialty pharmacy and get the prescription same day. Every single specialty drug that's dispensed from our facility, there is a coordination of benefits and copay assistance investigation conducted. So copay assistance is key, right? As an aside, the pharmaceutical manufacturers could care less what the employer or the municipality's share of the cost is, right? Because they know that there's funding there, there's dollars there to pay for the claims. What they do care is, for instance, should Mark be on a specialty drug, they could care less what NYSAC itself or the state plan pays on behalf of Mark's therapies. But what they do care is that they recognize that if all of a sudden Mark has a $1,500 copay on his specialty therapy, Mark might have to choose between paying his mortgage or paying for his copay. So organically, they've developed these copay assistance or patient assistance programs that are specifically intended to offset member out-of-pocket costs. So what they want to do is say, hey, if Mark's copay is $1,500, we'll cover the cost, drive it all the way down to $5, because they want to eliminate all barriers of access to their therapies from a financial standpoint, so that Mark doesn't decide to abandon the therapy altogether. So copay assistance and patient assistance is intended to support and alleviate financial stress to members. If leveraged appropriately, the byproduct of copay assistance and patient assistance is actual plan savings. So what we saw organically start to happen about 5 years ago, especially on the private employers group side, is we've empowered clients to know that there's all this funding available from pharma. Well, some of our partners have decided to, hey, as a way to mitigate specialty costs, we will artificially push cost onto the members and have ProAct specialty pharmacy offset those costs with patient and copay assistance. So I'll say that one more time. So in theory, if if Mark's copay was $50 through his municipal plan, the municipality would inflate the copay on specialty for Mark to $1,000, which on the surface would appear as if you're saving the municipality money by pushing costs onto Mark, and that's what it does look like on the surface. But what's happening behind the scenes at Noble is there's copay assistance investigations, and we're using pharma dollars to offset that copay exposure. So in order to protect the member in every single scenario, what we do is, should there not be enough copay assistance available on the market to support Mark's new copay levels, we would default back to the previous copay amount. So we would structure the plan in our system as Mark's copay is now 25 or 30% on specialty, but capped at an amount of $50. So the language of 20 or 30% allows us to go to pharma, advocate on behalf of Mark, secure those dollars, and in the event that there's not enough, always protect Mark. So it kind of gives the municipality the best of both worlds, allows us to pull down dollars to offset costs while protecting the member at all times. So that's probably one of the biggest strategies that are being leveraged today. Again, 1% of overall drugs dispensed are specialty, but they drive over 40% of the cost. So obviously a lot of time and attention. If leveraged appropriately, these copay assistance programs have the potential to reduce specialty costs by up to 70%. So very real dollars, very attainable, driving that lowest net cost. But what needs to be recognized, and which is oftentimes pretty challenging to kind of navigate, especially if there's union negotiated benefits in place, is getting all parties involved to understand that you can't necessarily drive lowest net cost for a plan without having without strategizing and recognizing that it's going to take some work. Unfortunately, there's no magic bullet, right, that's going to allow us to curb some of these cost trends. But if we're willing to come to the table and have discussions, candid conversations, and acknowledge the fact that, hey, if we get creative with our plans, there's significant dollars that can be captured from pharma to offset some of our costs while protecting the members. Now, I know that those aren't necessarily easy conversations to have with union groups, but nonetheless, we do have plenty of groups that are doing it today. And when you're faced with the decision of having to potentially face layoffs or introduce a plan benefit or a plan change that has a potential to reduce, potentially 40 to 50% of our costs, it does aid the conversation and support the overall intent, which is to drive that lowest net cost and preserve municipal dollars. Next slide, please. There's also network options. So for the most part, most of our, I would say 80 to 85% of our book of business has our broad pharmacy retail network. So that means that there's no pharmacies excluded at all. There are ways to get creative with regards to the pharmacy network. At the end of the day, what drives discounts and values across pharmacy chains is market share. So if you think of, say, CVS and Walgreens, probably two of the biggest pharmacy retailers in the country, they're always fighting for market share. So there are ways to have a reduced or a value network where we pick and choose, or we eliminate one chain out of the network. So if we go to CVS and say, hey, Walgreens is not in the network, but we need deeper discounts for this municipal group, at the expense of giving up more margin from their side, they will take the volume because they know that we've theoretically eliminated one of the competitors that they're going up against in some of these communities. That works very effectively in metropolitan areas, but if you're in a rural county, say Essex County that maybe has a handful of pharmacies, if you eliminate, say, a CVS or a Walgreens, you might theoretically be eliminating 70% of the access points. So not extremely popular in non-metropolitan areas, but nonetheless a solution that we can get very creative. Again, piecing together all these ancillary saving strategies to drive that lowest net cost. Next slide. In terms of clinical programs, so there's a handful on here. I'll kind of spend a minute on each one of them to give you a little perspective. The therapeutic alternative program, this is very similar to what I described earlier with regards to mail order. It's examining any utilization patterns that we see where there's a brand being dispensed, where there's a generic alternative available. Engaging those members, highlighting the value to them from a copay standpoint, and then articulating the efficacy as far as treatment plan is concerned from a clinical pharmacist perspective. And then we do incentivize them by saying, hey, if you switch from the brand that you've been taking to the generic, we will waive your first copay at mail order. So decent value there, probably 4 to 6% opportunity in terms of savings on the overall plan spend. Clinical optimization program. This is again focusing on high cost brands or high cost therapies that have alternative therapies that might be of lesser cost value to the plan. Opioid management program, obviously a lot of time and attention and focus across the entire country focused on opioids and handling of those programs. So there's some strategies that we deploy to support the clients in that realm with the overall intent of curbing misuse with regards to opioids. The specialty medication percentage copay program that I just described in the last slide. This is again playing around with the copay structure on specialty to allow us to go to pharma and pull down assistance dollars as a means to offset costs for the municipalities. Utilization management options. This is your quantity limits, your day supplies, your early refill, refill too soon programs, things like that, edits like that that are intended to protect the plan and also protect the member from a misuse standpoint. We have a standard diabetes management program, medical eligible specialty medications. So I expressed how significant of a cost driver specialty is on the pharmacy side or on the pharmacy benefit management side. There's still a whole nother significant chunk of cost that's being attributed to specialty drugs on the medical side. As a point of reference, on the PBM side, we price therapies as a discount off of average wholesale price or average AWP. On the medical side, so these are therapies that perhaps a specialist is sourcing themselves and administering at their office. Their pricing basis is actually multiples off of AWP. So while we might be working off of AWP minus 22%, a medical office might be working off of AWP times 2 or 3, so significantly more expensive when administered and dispensed on site at a physician's office. So we work with a third-party administrator to identify any specialty drugs that are being dispensed and billed through the medical side to pull them over to the pharmacy side, to the PBM side, where we can get significant value in terms of cost, but equally as important, actually drive some rebate dollars back to the municipality. Our strategies around new drugs to market. We obviously support and value some new therapies, especially when they have the potential to alter the lifestyle for some patients. But we're also realistic about the fact that it does take a couple months to have the proper due diligence conducted on behalf of the PBM. So rather than once a drug is approved by the FDA, just add them to the formulary, we do have what we classify almost as a waiting period, which is usually around 60 to 90 days, that allows our P&T committee to assess the efficacy, value, and overall benefits of some of these new drugs before we actually just add them to the formulary. Compounding program, compounded medications are not as much of an issue today, but 5 years ago, we had these specialty compounding pharmacies that organically popped up across the country. They would mix 3 or 4 ingredients that were often very cheap, low cost, maybe pennies on the dollar. They'd mix the ingredients together and they'd be classified as a compound drug, and they would cost, $4,000 or $5,000. We saw it oftentimes with regards to ointments. So we would see some claims come through for a couple different ingredients. Maybe it's an acne medication, and they bill the plan $5,000. We would decline the cost, and systematically we'd see the dispensing pharmacy continue to submit the claim at lower and lower amounts, because it was highway robbery across the country for a good amount of time. These compounded medications or therapies are just being dispensed at these astronomical levels, which when you break down the compounds in that therapy, it was just pennies on the dollar that they were mixing together and warranting or trying to warrant, thousands of dollars for some of these dispensing situations. Exclusionary formulary options. So it's essentially a broad formulary with no drugs excluded from coverage versus an exclusionary formulary option, which essentially eliminates, reduces the formulary. So it's kind of comparing, it's the equivalent of the two major insulin brands. We would eliminate one brand from the formulary. The value that's generated off of that is the manufacturer of the remaining brand that we're covering will drive additional rebate dollars to the plan. So the pure play on the exclusionary formulary there is the value from a rebate standpoint that would be coming back to the municipality. And then last but certainly not least, the split fill program, which comes in play mostly on oncology therapy. So if you think of a member that is recently diagnosed, we'll just use cancer as an example, their oncologist prescribes a therapy. There's some organic trial and error that occurs with regards to prescribing of some of these high cost therapies. So we never know how a member is going to react to a new therapy. So in the past, these drugs were being dispensed for 30-day supplies. I mentioned how expensive specialty is. So a plan might pay for a $5,000 drug only to find out 3 days later that patient does not react very well or is having significant side effects. So all of a sudden you have a $5,000 drug that was dispensed and the patient can't tolerate it. So that therapy, that supply gets destroyed or thrown away. There's dollars that were being thrown away. So there are some very specific therapies where we can actually implement a split fill strategy where instead of having a 30-day supply, if it's a new therapy to that patient, once it's gone through the prior authorization process, we would dispense perhaps a 10-day supply, validate and verify that the therapy is working for the patient, and then dispense the remaining portion of the regimen to ensure that it's the right drug for the right patient at the right time, but most importantly, protecting the dollars of the municipality. Next slide. We also have international mail order, right? So, and this is always a touchy one because we've got municipalities that love it. We've got other ones that want nothing to do with it. So, ironically enough, we do have the support of CSEA across New York State in support of CanRx. This is essentially an international mail order program that facilitates for members to get their maintenance medications delivered to their doorstep from an international source. These are tier 1 countries, so Canada, Great Britain, New Zealand, and Ireland. And they're oftentimes being sourced from the same manufacturing facilities that supply your local Rite Aid or Walgreens. It's only brand name maintenance medication. So the irony of it all is that oftentimes people assume in the United States that their brand name medications that they source at their local pharmacist is actually produced in the States, and it's actually not accurate. Over 90% of the brand name drugs consumed in the US are actually coming from overseas. So theoretically, what this program does is it's facilitating for the equivalent of what Bernie Sanders was doing in Vermont years ago. He'd load up a bus full of senior citizens, drive them across the Canadian border. They'd take a valid prescription, pay for their therapies cash, and he'd drive them back over. The value to an overall cost is these drugs are 65 to 85% cheaper than their domestic equivalent in the US. The value to the members is that it's voluntary and it's a zero copay program to them. So there's no no disincentive for them to not try the program. It's free. If it doesn't work, they can always transfer their therapy back. And again, sourcing from tier 1 countries, over 350 brand name medications. And our systems are integrated to ensure that there's no drug interactions. The last thing we want to have happen is that a drug is dispensed, comes in from Canada, and the member is also on a therapy at their local Rite Aid, and that our systems are not talking, facilitating for a potentially dangerous or hazardous situation for the member. So this is a huge, huge value to employer groups. So we do tend to see it be much more prevalent on the private employer group side. But again, if there's appetite and desire to, again, drive that lowest net cost scenario, this is another ancillary saving solution that can really help us accomplish that goal. And then current municipal partners. So just to give you some perspective in terms of our depth and strength across New York State, we currently have contracts or partnerships in place with 65 New York State municipalities. So that does include counties, cities, and townships. Specific to counties, I believe the number is 13 at this point. Looking broadly at how many members or lives we cover across New York State, so municipalities, school districts, private, public employers, we're responsible for the dispensing of pharmacy healthcare needs for 176,000 members across New York State, dating back to 1999. We're working in virtually every county, one way or another. We're touching those counties, whether it's with our PBM services, or as Mark stated, we do manage the prescription discount card program that's been in place for a very long time at this point. And we're shipping prescriptions to virtually every zip code as well, coming out of our central fill location or mail order facility in Governor, as well as our specialty pharmacy right here in East Syracuse. As I mentioned before, while we aren't, selling new business at the rate at which some of the other market players are, the ones we are lucky enough to call partners someday tend to have a pretty significant tenure with us. And right now, our municipal client base, that tenure sitting over 9 years on average across the board. And then just to close things up before we shift to the Q&A, who is eligible? All members of the New York State Association of Counties. NYSAC's partners are our partners, and it would please us. It would please us immensely to have the ability to support those employee pharmacy benefits in one way or another, whether that's as your PBM or serving in an advisory capacity to help support you in conversations with your existing vendor to hopefully optimize the existing offering if you find that you're not in a place where you're looking to make a change at that point. Counties that will realize the greatest value from this plan, 2 key metrics. They must be self-insured or fully insured with usually over 100 or more employees / dependents. Anything below that tends to be significantly risky for the municipality. So that's all I had in terms of slides. Mark, I'm gonna tag you back in to maybe coordinate the Q&A for us.
Great, thank you, Harrison. Great information, I appreciate that. For our attendees who are on this webinar, in your dashboard on the right-hand side, at least it's on my right-hand side, you have a panel called questions. If you would like to submit any questions for Harrison, now is the time for you to do that. Harrison, you're an MBA and you own ProAct. You're an employee owner of ProAct. As you look out over the horizon, or what are the trends in PBMs that you're seeing in New York State or across the nation?
I would say it's wholeheartedly focused on the specialty spend, right? We see that number continue to grow in terms of the percentage of overall total plan spend for municipalities or employer groups, anyone self-insured to that point. So what the market is yearning for immensely today is solutions and strategies that can curb or help erode some of those cost factors. And it's just requiring employers across the country to just get creative, because we can no longer mitigate cost trends by merely just desiring it. We actually have to deploy actions and strategies and work with PBMs that are nimble enough to deploy strategies that at their own expense, at the expense of margin erosion on their part, they know that leveraging pharma or leveraging international mail order are the cost mitigating strategies that have the ability to drive lowest net cost.
Great, and you mentioned part of this in your presentation. There are fewer and fewer PBMs out there, right? Because of the monopolization of PBMs, the PBM structure, environment. So then, can you just talk a little bit about what sets ProAct apart? Because you're not being bought up by those big PBMs that are taking over the market.
Yeah, I appreciate that, Mark. And in terms of what sets us apart, I'd have to come back again to that employee ownership aspect, because 5 years ago it was a market that was significantly driven by discounts, rebates, and clinical programs. But the truth is, in terms of that diversification of the market, it's kind of leveled the playing field in the mid-size PBM space, where we all have access to the same discounts, the same networks, same talent base. It's really focusing on what sets you apart. And for us, it just so happens to be that, that one attribute that no other PBM across New York State or the country to that point can state, which is their ownership structure is 100% employee owned. And, for us, the ownership structure aligns our interests, right? We know that we as employee owners are successful when our clients are successful. So we each have a vested interest in ensuring that day in and day out, we put our best foot forward. And it drives the tenure of our employees. It's not surprising to see folks with 45 years of service across our broader KPH organization, because again, there's that value, that pride and employee ownership, but there's also the wealth creation component of being employee owned that happens organically the longer you stay here. So again, that vested interest in ensuring that our success is defined by how successful our clients are.
And we recognize that as your partner. And I just want to, to take it one step further. You're an employee-owned business in New York State. So you're employee-owned and you're in New York State. So it's like a double benefit for a municipality in New York State, because you know that when you work with ProAct, you're working with somebody who's committed to their clients and their customers and the people that they employ, and those are New Yorkers, right? So we appreciate our partnership because we see that day in and day out with ProAct.
Absolutely, and we appreciate the support and advocacy over the years. We recognize, right, that there's going to be solutions and scenarios that may make ProAct not the ideal solution, which is why I want to keep coming back to the fact that, we want to be here for the municipalities and the communities that we call home, whether that's in an advisory or support as an advisor or support from a support standpoint, or if we're blessed enough to someday be able to manage the employee prescription plan. We know that there's value out there. We know that there's always an ability to do and find it a bit better. And we know that organically these conversations will continue to occur. We just celebrated our 22nd anniversary, and our hope is that 20 years from now we're still having the same types of conversations, that we continue to be independently owned by our employees, and that we haven't had a need to sell or be acquired by another organization.
Great. Two more questions, Harrison. One is, what keeps you up at night?
These days, honestly, there's a lot of talk and noise at the federal level surrounding transparency efforts. And rightfully so. I think that there's some scrutiny that needs to be placed on our industry. I think for a long time, there's been a lot of misinformation out there as far as understanding the PBM industry. We know that we know the price tag that employer groups are paying as far as pharmacy. But I think that there's been some intentional cloudiness to our space intended to keep the payers or the employers from understanding how these contracts work. So finally, there is some activity at the federal level that is kind of dispensing down state by state. We're seeing licensing requirements for the first time in a long time, state by state. So that requires us to be focused and hypervigilant to how these state mandates are changing day to day. But most importantly, I'm not afraid to be compliant in all these states. But most importantly is to keep the employer groups educated and well versed on what these changes mean to them individually. Because we're gonna, 10 PBMs are gonna interpret legislation 10 different ways. So just keeping our client base in tune with what's going on surrounding state licensing requirements and federal mandates at this point.
Great, and thank you. And so for a county who is self-insured, who it wants to look, either they want to carve out their PBM or they want to explore PBM to see if they can bring savings or effectiveness or efficiency to their PBM program, how do they get in contact with ProAct?
So they can email our sales alias. So it's up on the screen, sales@proactrx.com. They can reach out to us via our website, proactrx.com. If they feel more comfortable navigating through the team at NYSAC, either way, we're happy to support and have those conversations.
That's great. Thank you very much. You've heard from Erison Rodriguez, the Chief Growth Officer at ProAct, a longtime partner of the New York State Association of Counties. Thank you again for your time this afternoon, and we look forward to continuing to work with you.
Thank you, Mark. Appreciate it.